Hello friends, welcome to JIG's Rapid Journal Review. So this is the third journal review. So I'll be discussing this interesting article that came, Methylene Blue in Septic Shock. So I wish to acknowledge my colleagues, Dr. Rajshekhar and Bhavya, who also discussed this journal. So when we look into the sepsis, so we have very few options with regards to maintaining blood pressure. So just looking back and revisiting our definition, it's a life-threatening organ dysfunction due to dysregulated host response to the infection. So what really happens in sepsis is we have a lot of vascular leakage. And when there is vascular leakage, obviously there is fluid deficit. So our understanding is we give fluids. And what we have understood is there is vasodilation also that happens because the nitric oxide metabolism becomes abnormal in sepsis. This leads to vasodilation in addition to a lot of fluid leakage that happens from the vessel, which leads to hypotension, hypoperfusion, and deleterious effects. So the options we have is we give fluids to circumvent this lot of fluid leakage that happens from the blood vessels. And it is shown that only half of the patients respond to the fluid resuscitation that is being given. And the hemodynamic effects that are attained after giving fluids is only transient because whatever fluid is given, it does tend to extravasate. And again, it uh, reverts back to the baseline. So it is shown from one study that hemodynamic effects last only for about 10 minutes with regards to fluid resuscitation. So beyond this, because there is vasodilation, we use vasopressors. The second option is we use vasopressors. And some of it has shown that increasing the dosage of these vasopressors lead to some deleterious effects. So it can cause arrhythmias and there can be organ ischemia or myocardial ischemia that can happen and some immunosuppression. So these are some of the deleterious effects. Obviously, we use vasopressors, but perpetuating and increasing or cascading the dose of vasopressors can lead to deleterious effects. So that is where we need to have a third option. So we use fluids for septic shock, we use vasopressors, and we use some steroids. But is there a need for a third option? So this is where the whole question of usage of methylene blue comes in. And there is a sort of a understanding that one needs to approach management of septic shock in a multimodal strategy to improve the tissue perfusion and at the same time reduce the toxicity of multiple vasopressor that we would be using or using a very liberal amount of fluid because increasingly we have recognized using a lot of fluids also is deleterious, using a lot of vasopressors also is deleterious. So this is where the context of whether we need a third sort of a drug which can play a role in stabilizing the organ perfusion is the need of the hour. So to fit into this space is the molecule which is methylene blue. So this is the chemical structure of methylene blue, which is phenothiazine-like heterocyclic aromatic molecule. So that is the molecular structure. And how does methylene blue act? Because we know how vasopressor acts, we know how fluids help in circumventing the extravasation of the fluid. So we need to understand how methylene blue acts. So the whole concept of vasodilation that happens in septic shock is mediated by nitric oxide, which acts on the vascular smooth muscles. So nitric oxide synthase, I'm sure most of the listeners would know, nitric oxide synthase, which is present, produces nitric oxide. And this nitric oxide leads to activation of soluble guanylate cyclase. And this soluble guanylate cyclase leads to production of cyclic GMP, guanosine monophosphate, and this leads to activation of protein kinase. So this is the sort of a cascade that tends to set in with nitric oxide. This protein kinase, what it does is basically the smooth muscle that contracts is mediated by calcium entry into the calcium channel. And the activation of the protein kinase reduces the sensitivity of myosin to contract due to the calcium entry into the calcium channel. So there is reduced sensitivity of myosin to the calcium that gets mediated by this activated protein kinase. And there is this calcium sensitive potassium channels which gets activated. And this activation of this calcium sensitive potassium channels leads to reduced entry of calcium into the calcium channels. So all this leads to uh, vasodilation due to the dilatation of these smooth muscles. And there is inhibition of calcium release by this endoplasmic reticulum, which is present in the muscle. So these are some of the changes which I put in pictorially, which tends to happen due to activation of protein kinase. So there is reduced calcium entry into the muscle due to the activation of calcium sensitive potassium channels. There's inhibition of calcium released by this endoplasmic reticulum and reduced sensitivity of myosin. So these are the three components which leads to muscle relaxation. So because there is a smooth muscle relaxation in the vascular smooth muscles, vasodilation happens and hypotension sets in. So nitric oxide or the methylene blue acts by inhibiting the nitric oxide synthase and it acts by inhibiting soluble guanylate cyclase. So this is the mechanism of action of methylene. So methylene blue basically acts on this pathway and prevents the relaxation of vascular smooth muscles, thereby preventing vasodilation and deleterious side effects. So this is the mechanism of action of methylene blue. So you can remember this picture to understand how it acts. So there are certain basic science studies done as to how methylene blue has an effect on pharmacodynamics. So way back in 1999, as you see, early studies with methylene blue happened since 2 decades. So this came from Brazil, where they showed methylene blue in the physiological models does increase the mean arterial pressure, and it was shown to increase the SVRI from baseline by in 60 minutes. SVRI increases. Pulmonary vascular resistance index also increases in about 20 minutes. Mixed venous oxygen comes down from 65 to 63 in about 60 minutes. And PaO2 by FiO2 reduces with the use of methylene blue in about 40 minutes in this physiological study. And lactate reduced from 5 to 4.5 in this study. With regards to heart rate, filling pressure, cardiac output, oxygen delivery, and oxygen consumption, there was no difference with methylene blue. So this was an early physiological study done from Brazilian authors, which showed these are some of the hemodynamic effects that methylene blue has, and we need certain of these hemodynamic effects in sepsis. We need reduction of lactate, we need improvement in the SVRI, and so on and so forth. The PaO2 FiO2 reduction is due to the methemoglobinemia that happens. So there is an underestimation of this oxygenation that happens, which we will talk about in the later slides. And it is shown that methylene blue at the dosage of 1 milligram per kg is found to be very safe. Once we go beyond 1 milligram per kg, uh, up to 1 to 2, it is okay, but more than 2 milligram per kg, it is shown to cause hypoperfusion. So any dose after, because in the study that we will be talking, cumulative dose of 1.2 milligram per kg was used. So any higher dose, so more than 2 milligram is something you can keep in mind. It causes splanchnic hypoperfusion, leading to some organ ischemia that can happen. So that is something one needs to bear in mind. So this was a study that came from the German group in 2022, looking at what is the right sort of a dosing that has to be used in methylene blue. So this title of the study was Methylene Blue Dosing Strategies in Critically Ill Adults with Shock. So this study was a retrospective cohort study done from July 2014 to October 2019. So here they used methylene blue in patients with shock where norepinephrine requirement was more than zero point 0.1 micrograms per kg per minute, and lactate use was more than 2 millimoles per liter. So these were the patients where they used methylene blue. So they had 209 patients in this particular study, and they used 3 different dosing patterns. As you see, 111 patients got a bolus of methylene blue followed by continuous infusion. 59 patients got only bolus of methylene blue, and 39 patients got continuous infusion. So just focus on this study because the study that we are discussing today, they used only continuous infusion. But in this particular study, which came from Germany only last year, they used these 3 different doses to see which sort of a dosing had maximum efficacy. So baseline characteristics in these patients, there was no difference. Then they looked at vasopressor index score. So vasopressor index score, as I have shown here, is only addition of all the vasopressors that was used, dopamine plus dobutamine, and epinephrine and vasopressin and norepinephrine, they multiplied by 100 to derive a vasopressin index score. And they found basically the cumulative need of vasopressors significantly reduced in all 3 groups. Either you use bolus followed by infusion, or infusion or only bolus, the need for vasopressor significantly came down. But when they looked at 28-day mortality, that was found to be significantly less in patients who got bolus followed by continuous infusion. It was 53.1% was the 28-day mortality, but when in the patients who got only bolus, mortality was 71, and who got continuous infusion, mortality was 74.3%. So, which goes to say the type of dosing that we use is going to influence the outcome, at least from this German study, if you have to subscribe, because the 28-day mortality was significantly less in this group. And it was shown that in patients with cardiogenic shock or in patients who need higher dose of vasopressors, there was better response to methylene blue. So this was shown in this particular study that anyone who is needing cascading doses of vasopressors or where there is a cardiac dysfunction also, the response to methylene blue was found to be much better. So this was an important message that came from this study that you give as a bolus followed by infusion, they seem to have better effect on the outcome, and patients who are on higher vasopressors tended to respond better to methylene blue. So these were the two high points of this particular study. And the adverse effects, as I said, methylene blue is considered safe in less than 2 milligram per kg. More than 2 milligram per kg, the vasoconstriction and the organ ischemia can set in. And one of the commonest side effects of methylene blue is this greenish colored urine that tends to happen. So this was found in significant number of patients who got methylene blue. And arrhythmias was also one of the side effects, and depressed cardiac output and increase in the pulmonary vascular resistance. So these were some of the side effects. And even some of the patients had coronary ischemia when higher doses was used. And renal hypoperfusion is the side effect, and depressed saturation because of the methemoglobinemia that forms. The saturation can be falsely depicted as being low. So these are some of the adverse effects one needs to keep an eye on when methylene blue is being used. So keep the dosage of 2 milligram per kg in mind. So anything more than 2 is going to be harmful in a day. So that is something one needs to keep in mind. So contraindications for methylene blue, any hypersensitivity, and in G6PD deficiency, methylene blue can cause hemolysis. So one needs to exercise caution with the usage of methylene blue in G6PD deficiency. And it has some drug interactions. It does interact with monoamino oxidase inhibitor and SSRIs, and it does interact with dapsone, leading to production of this hydroxyl amine group, which leads to hemolysis. So hemolysis is something one needs to keep an eye, especially in patients with G6PD deficiency or someone who's on dapsone. So these are some of the things that one needs to keep in mind. So this is about all the background that I've spoken with regards to the information that one needs to have on methylene blue. Now we'll jump into this study, which is what we will focus on in this journal review. So this came, as you see, in 2023. It is a Mexican study. So early adjunctive methylene blue in patients with septic shock, a randomized controlled trial. So this was a single-centered randomized controlled trial. Inclusion criteria was they took patients with septic shock who fulfilled the sepsis-free definition. So the primary outcome, they looked at time for vasopressor discontinuation at 28 days. So how much time it took for them to stop vasopressor. Secondary outcome, they looked at vasopressor free days at 28 days. They looked at duration of mechanical ventilation. They looked at ICU and hospital length of stay, and they looked at 28-day mortality. So these were secondary outcome they looked at. So the methods, so they took care that enough fluid resuscitation was given, and the fluid resuscitation or the fluid responsiveness was determined by our accepted dynamic indices. They looked at velocity time integral change of 10% with passive leg raising test as a indication for giving fluids, and they looked at positive pulse pressure variation of 13% as a reason that they had to give fluids, and they looked at tidal volume change with a change of 3.5% as a reason they should. So just put this in the context of the Clover's trial that we discussed last week. In Clover's trial, they never used any of these indices to give fluids. They only looked at clinical variables. But at least in this study, where they're using methylene blue, the initiation of vasopressors was only happened after adequate fluid responsiveness test that was done and fluid resuscitation guided by these tests. which is good. And they started norepinephrine. If norepinephrine dose went to more than 0.25 micrograms per kg per minute, vasopressin was started at 0.03 international. As these were all the standard therapeutic regimes that we adopt in our ICU. And they started hydrocortisone 200 mg as an infusion in anyone who are on vasopressors or who are on an increasing vasopressor. And this whole dimensions were put in place to maintain map of 65 to 75 millimeter mercury. So the sample size was calculated. Sample size was 88 patients. This was to attain statistical power of 80% with alpha error of 0.05. So this is the statistical methodology they adopted. So results, so I'll just straight away jump to the results. They enrolled 91 patients. The median age of the patients in the study was 46 years. Interquartile range was 35 to 55. 60% of them were male patients. 46% of the patients had AKI. And the source of sepsis, pulmonary was the main source of sepsis in the study, with 49.5% of the patients who had pulmonary as the source of sepsis, and 38.5% of the patients had abdominal as the source of sepsis. And antimicrobials or antibiotics were administered within 3 hours. So all this is in keeping in lines with the surviving sepsis guidelines. So they adopted all these principles. So which means it was a well conducted study. So they had this 91 patients, and we'll straight away look into the key aspects of the results. They looked at time for vasopressor discontinuation at 28 days. As you see, it was much earlier. So the time that was taken to stop vasopressors was much earlier in patients who got methylene blue. 45 got methylene blue, 46 was placebo. It was 69 hours as compared to placebo, where methylene blue was not used, 94 hours, which means in the group which got methylene blue, the vasopressors could be stopped much early on, and that attained statistical significance. And the dose of methylene blue they used for these patients was 100 mg per in 500 ml normal saline. It was given as an infusion over 6 hours for 3 days. So keep this in mind, because when we compare this with the German study, which said that giving a bolus followed by infusion had a better effect on the outcome as compared to only the infusion. Here they gave 100 mg and they took 1.2 milligram per kg as a dose for this study, and they put it as 100 mg as a ballpark figure. So that was the dose that was given to all the patients. And vasopressor free days, the higher it is, better it is. As you see, vasopressor free days was higher in 23.9 days in methylene blue and 19.5 days in placebo, and that also attained statistical significance. And so there was a median difference of 1 day more. Vasopressor free days was better by 1 day in methylene blue group. And they looked at ICU length of stay was significantly less in methylene blue group, and the median difference of ICU length of stay being less was by 1.5 days in methylene blue. So they stayed 1.5 days less in the methylene blue group as compared to the placebo. And the hospital length of stay also was significantly less in methylene blue group, 9 days as opposed to 10.5 days. So the median difference was 2.7 days, which means they stayed less by 2.7 days in the hospital in the methylene blue group. So very, very optimistic, very provocative sort of an outcome where your duration of vasopressors was significantly less, time taken to discontinue vasopressors was significantly less in methylene blue, ICU length of stay, hospital length of stay, which are important secondary endpoints that we looked in any study, were significantly less in methylene blue group. And these were the positive outcomes. They looked at duration of mechanical ventilation and mortality. There was no difference between methylene blue and placebo. And they looked at adverse events. 91 patients, as I said, methemoglobinemia is something which is a problem with methylene blue. And methemoglobinemia is shown to be dose responsive or dose related. It all depends on the cumulative dose. So it was 2.9% in methylene blue, and placebo it was 0.5%. And this greenish urine was found in almost all patients who got methylene blue. 93% of them had this greenish blue urine. And they looked at all the ejection fraction, because we understand when we give methylene blue more than 2 milligram per kg, it can have coronary ischemia, arrhythmias, and depression in the cardiac output. They have looked at ejection fraction. They have looked at acute kidney injury, PaO2, FiO2, aminotransferases, and bilirubin. There was no difference at the dose they have given in this study. It was 1.2 milligram per kg or 100 milligram as an infusion. for 3 days. So basically, they gave 3.6 milligram per kg over 3 days. So that is the cumulative dose that was given in this study. And when you look very carefully into all the tables that are put up in this study, so you would look, they looked at days of mechanical ventilation. If you see, the signal is more towards reduction in the methylene blue group. It was 4.2 to 5.5, 5.1, and almost attains statistical significance. And even if you look at serum lactate at the end of 24 hours, it was much less. The signal was more towards being very less in methylene blue as compared to the placebo and almost attaining statistical significance. So it basically shows maybe if the sample size would have increased, we could have possibly attained statistical significance even here. And these are the baseline characteristics between methylene blue and the control. As you see, there is no major difference in any of the baseline characteristics. But what is of interest that I wanted to show is the SOFA score and Apache 2 score in this particular study. Compare this with the Clover's trial that we discussed last week. In Clover's trial, which was comparing restrictive and the liberal fluid, you saw the SOFA score was only 3, and that was mentioned as a limitation of the study that they took possibly less sick. Here, if you see, the SOFA study is much higher, and even the Apache is much. It means they took all sick patients with septic shock. So it basically reflects about the sickness quotient in these patients, which tends to define that possibly this was a study looking at a sick, critically unwell patients who are on cascading doses of vasopressors. And here, if you see the norepinephrine dose, the blue one is the methylene blue, significantly comes down as compared to the placebo. And if you see this, the dark gray one is the map, which significantly improves as compared to the placebo. So, and this is the Kaplan-Meier curve looking at the vasopressor discontinuation. As you see, the vasopressor discontinuation happened much better with the methylene blue group with hazard ratio of 2.7. And as you see, confidence interval was statistically significant. So that's what are all the positive findings that was observed in this particular study. So, what are the strengths of the study? One would think that 91 patients possibly is a less number, but compared to all the previous studies, the strength of this is the largest study so far. Even with 91 patients with 45 in methylene blue group, this is the largest study so far. Let's look very briefly into the previous study. This was a study which had come from Russia, Kirov et al. In 2001. Only 20 patients they looked at where they used methylene blue at a dose of 2 mg per kg and followed by 4-hour infusion. Maximum they went up to 5.75 milligram per kg. And they found that methylene blue had less death, 3 versus 7, but it did not attain statistical significance. And duration of vasopressors also was less. Even in that study, about around 20 years back also, it was shown that methylene blue had a favorable effect, but it was a very small study, did not attain statistical significance. This was a study by Turkey, Memis et al. In 30 patients, where they used methylene blue 3 milligram per kg, a 6-hour infusion, and they found the methylene blue group had a better map. And this particular study, they did cytokine levels. And it was expected that methylene blue group should have less cytokines. So cytokine levels, they did not find any difference between the methylene blue and the placebo group. So what possibly tempered or underwhelmed the usage of methylene blue possibly may have come from this study by Lopez et al. This came from the Spain. This again came in 2001. Very big study. It was a very enthusiastic study of 797 patients conducted by Spain group. Here they used nitric oxide synthase inhibitor, which is methyl L-arginine hydrochloride, which is similar to methylene blue, and they compared with placebo. So this was a hugely negative study where they showed the usage of nitric oxide synthase inhibitor because methylene blue also is a inducible nitric oxide synthase inhibitor. Here they found 10% increase in the 28-day mortality in patients who got this nitric oxide synthase inhibitor due to cardiovascular events. So they had a lot of myocardial events. So the authors argue in this paper, this nitric oxide synthase inhibitor, which is a methyl L-arginine hydrochloride, is a non-selective inhibitor of inducible nitric oxide synthase and constituent isoforms. So the argument they make is methylene blue is only a selective inhibitor of only inducible nitric oxide synthase, but this nitric oxide synthase inhibitor which was used was a non-selective inhibitor that may have led to more deleterious cardiovascular side effects, is what the author subscribed to. And we did see that methylene blue causes reduction in the PaO to FiO2. The argument is we deal with patients who have septic shock and ARDS. So it is imperative that we do not want FiO2, PaO2 by FiO2 to go down further. So these are some of the studies which are showed. This was a study by France, Gachot et al., where they showed PaO2, FiO2 reduced from 229 to 162, where they used 3 mg per kg of methylene blue over 10 minutes. And this Brazilian study we did show earlier also, where PaO2, FiO2 comes down from 168 to 132, and the dose they used here was 4 mg per kg or 4 hours. In this study, the cumulative dose that was used was 3.6 mg per kg for 54 hours, and none of these patients showed reduction in the PaO2 by FiO2. So basically, the argument is, so the cumulative dose that is used for a much longer period of time. Here, the cumulative dose is in this particular study was 3.6 milligram per kg or 54 hours. But if you look at the earlier studies, there was this dose 3 mg given over 10 minutes and 4 mg per given over 4 hours. So possibly that may have led to reduction in the PO2 is the argument that the authors make. So this study where they have used over 3 days, 1.2 milligram per kg did not have any effect on PO2 by FiO2. So what are the limitations of this study? The limitation is a single center study, and many of these patients who were shifted to ICU were shifted very sick from other departments, and the type of treatments adopted for sepsis in the department, from operation, from the surgical inpatient, from the medicine inpatient, were quite varied. So there was huge heterogeneity in the treatment practices that were adopted in the wards. And this study took many years to complete because of the COVID. There was a lot of interruptions in this study, and this could have sort of influenced the outcomes that was witnessed in the study. And one would argue that one should have measured any physiological changes that nitric oxide would have caused by measuring cytokines, nitrates, and nitrates. This was not measured in this study. And COVID-19 patients were very conveniently excluded, and we do not know for sure whether in COVID-19 sepsis patients, methylene blue would produce such phenomenal results. We do not know. And another important thing is, although they would say that this is a randomized control blinded, so the blinding was not possible because 93%, almost all patients had this greenish urine. So there was no obvious blinding of methylene blue group versus the placebo group. So this could have infused certain bias with the way the whole vasopressors were titrated in the methylene blue group is an argument. So these are some of the limitations that authors do subscribe to or do concede to in this particular study. So the conclusions from this study is methylene blue versus placebo. Methylene blue patients showed significant reduction in the time needed for discontinuation of the vasopressors, and it significantly methylene blue group had reduced ICU length of stay and hospital length of stay. So, so very provocative and very optimistic sort of results that we could see. And the reason we are discussing this journal is because methylene blue is not a standard of care in patients with septic shock who are on vasopressors. And we use vasopressors, we use fluids, we use hydrocortisone. But I'm sure many of my listeners would agree that we do not keep methylene blue as one of the tool in our armamentarium for septic shock. So whether this study will change the practice is something which raises our enthusiasm. After all this, so there is one nice meta-analysis which has come from China again in 2022. Efficacy and safety of methylene blue in patients with vasodilatory shock, systematic review and meta-analysis. They have taken 15 studies which has looked all the small. So the largest study is this Mexican study, 832 patients. They have looked at methylene blue plus vasopressor and the only vasopressor group. And if you look, again, very overwhelmingly enthusiastic findings. Mortality odds ratio was 0.54 in patients who got methylene blue and vasopressor as compared to vasopressor. And if you see confidence interval, statistically significant. So there was the mortality benefit in patients who got methylene blue along with vasopressor from this meta-analysis. And the vasopressor requirement, the median difference was significantly less when methylene blue was added to the vasopressor, again attaining statistical significance. And the methylene blue group had higher MAP, higher heart rate, higher pulmonary vascular resistance, and reduced risk of acute kidney injury. So the conclusions that was made in this meta-analysis was, which I thought I will leave this talk with this meta-analysis, which again overwhelms us with enthusiasm that methylene blue is possibly something that we need to include in our armamentarium. Methylene blue, when added to vasopressors, significantly improves the hemodynamics, reduces the vasopressor requirements, reduces the lactate, and improves the survival. So this was a very provocative sort of a conclusions that was made in this particular meta-analysis. So all in all, so when I look at this Mexican study, when we look at this meta-analysis, it appears very compelling for us that possibly we should consider keeping this in our armamentarium in patients with septic shock after our optimal resuscitation with fluids and after optimal vasopressors. If there is a cascading need of increasing vasopressors that is happening, maybe we should throw in methylene blue is what appears from this study. Maybe we still need larger studies in larger group of patients in a multicentric format to make logical conclusions. So I will leave it to Anirban to make discussions on this. So thank you, one and all. So this is a forest plot. As you see, there are around 10 studies which are shown favoring methylene blue. So thank you, one and all.